Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is August 7, 2025. This videocast is an article released yesterday in the JACC journals on 6th August 2025. Free access, 2025 concise clinical guidance, an ACC Expert Consensus statement on the diagnosis and management of pericarditis. Pericarditis is inflammation of the pericardium, often idiopathic or viral in high-income countries, classified into acute, recurrent, incessant, or chronic based on duration and symptoms. Can be inflammatory, where there is increased CRP and fever, or non-inflammatory, example autoimmune, CRP normal. Complications include pericardial effusion, tamponade, and constrictive pericarditis. This document has novel diagnostic criteria for pericarditis. Essential is pleuritic chest pain or equivalent presentation, plus one or more of pericardial rub, EKG changes including diffuse ST elevation or PR depression, increased CRP or ESR, pericardial effusion and imaging or pericardial inflammation on cardiac MR or cardiac CT. If there's only it's greater than 0, as unlikely having pericarditis. If there's only one of these criteria, then it's possible, and more than 2, it's definite. This also includes classification by duration. Duration of pericarditis classification: acute pericarditis, an event lasting less than 4 to 6 weeks; incessant, event lasting greater than 4 to 6 weeks without remission; recurrent, new episode with signs and symptoms of pericardial inflammation after a symptom-free interval of 4 to 6 weeks; and chronic, event lasting greater than 3 months. Imaging modalities: transthoracic echocardiogram, first line for effusion, tamponade, chamber collapse and constriction; cardiac MRI with LGE or T2 stir to detect inflammation and edema; pericardial thickening when it's greater than 3 mm thick; cardiac CT, best for calcifications and surgical planning, alternative to cardiac MRI when contraindicated. Imaging guides diagnosis, grading, and management. So imaging is really important. Management approach: first line NSAIDs, aspirin and ibuprofen with colchicine, at least 3 months in acute pericarditis and 6 to 12 months in recurrent pericarditis. Exercise restriction advised until remission. Second line agents include anti-IL-1 like rilanocept, anakinra, or corticosteroids for refractory cases. Radical pericardectomy for chronic or refractory pericarditis at expert centers. Pericardial disease centers and follow-up. Pericardial disease centers offer multidisciplinary care and reduce admissions. Care includes triage, imaging, personalized plans, and patient education. Follow-up every 3 to 6 months, including labs, EKG, and imaging. Pericardial disease centers also enable clinical trials, research, and high-quality care. Malignancy-associated pericardial disease. I'm a cardiac oncologist. Cancer is a recognized cause of pericardial effusion, often presenting with large or recurrent effusions. Most common malignancies: lung, breast, lymphoma, leukemia, and metastatic disease. The effusion may be inflammatory or non-inflammatory, and cytology may be negative despite malignancy. Echo is the first line of diagnosis. Cardiac CT and cardiac MRI may assist if malignancy-related pericardial thickening, calcification, or a mass is suspected. Pericardiocentesis is diagnostic and therapeutic, evaluate for cytology, tumor markers, and possible tamponade. Again, multidisciplinary care involving oncology is essential. Recurrent malignant effusions may require pericardial window or indwelling catheter. IL-1 inhibitors are not indicated unless there is an inflammatory phenotype without tumor involvement. Palliative care input may be necessary in advanced cancer cases. Frequently answered questions: what's the most common cause? Idiopathic or viral in high-income countries, TB in lower and middle-income countries. Is CMR always required? No, but useful in recurrent or complicated cases. Can NSAIDs be avoided? You have to consider alternatives when there are contraindications like chronic kidney disease and GI bleeding. Is colchicine mandatory? Strongly recommended, reduces recurrent risk. When to refer to a pericardial disease center? Recurrent and chronic cases or those needing biologics or pericardectomy. This is an outstanding document. It's available open access on JACC. Encourage all of you to read it. Celebrities diagnosed with pericarditis include Harry Kane, English soccer player, diagnosed in youth; Amir Khan, British professional boxer, early career episode; Andrew Luck, NFL quarterback, sidelined 2015 season; Raymond Felton, NBA player, he missed games; Mike Taglieri, NFL analyst, publicly shared recovery story; Tony Braxton, singer, had lupus-related pericarditis; Carly Pearce, country artist, had recurrent pericarditis and effusion, which she discussed publicly in 2022. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.